I have put this PowerPoint slide series together. Some of them are the same as last year, and others are different. So I will load this one onto Blackboard for you. Essentially, I just want to, basically, this is exactly what I just told you. The plan is to talk to you about the diagnosis of cancer, and then to talk to you about some of the treatment strategies. I think this is really, well, first of all, interesting, and secondly, important for you if you're going to be studying a module about cancer biology. So, just tying this back to the assessment outcomes for the module, one of the assessment outcomes is to understand how diagnosis of cancer happens and different strategies for this. So, obviously, all of this is tied in to your coursework, and of course, if I can just mention the dreaded exam at the end. So all of this will be tied in to the exam at the end. You are welcome to interrupt me or ask questions as we go along. In the absence of that, I shall just tell you things that I think are interesting and important for you to know. And I suppose the first important thing to know is that really the diagnosis of cancer is an evolving process which hasn't stopped today and isn't cast in stone. It is an evolving process. These days we have guidelines based on many, many clinical trials and all sorts of different evidence which essentially push us in one direction for the diagnosis of cancer. But as you'll see, the development of molecular biology techniques and our understanding about the changes in cancer mean that this diagnosis lecture in 5 years' time could be quite different to what it is today. Okay, so things are changing quite considerably. Most of what I'm going to tell you is about breast cancer. That's because that's my specialist area, but I'll try and throw in other examples here and there as we go. You will notice on the list of topics for the coursework, breast cancer isn't there on the list, and the reason is because we are giving you quite a lot of information about breast cancer as we go along. Okay. So with breast cancer, actually, as with many other types of cancer, you normally have a triple type of assessment. So one thing won't tell you everything. One type of assessment wouldn't tell you everything you need to know in order to diagnose a cancer. So, for example, clinical examination on its own won't tell you whether or not a patient has got cancer. There needs to be additional molecular or cellular type of approach. However, in order to get a diagnosis of cancer, really the first step would normally be a clinical examination or some sort of imaging. Now, it's important to remember that there are two sorts of types of cancer really. There's what's called symptomatic, and there's asymptomatic. So there's the two types. One is symptomatic, obviously as it implies, the patient has a symptom, and so they go to their, normally in the UK, they would go to the GP as first port of call, and they basically would have a symptom which would be investigated by clinical examination. That would then be followed up, if it was suspicious, and generally with anything that's vaguely suspicious, it would then be followed up with imaging. Now, some of you who may be old enough to know, or whose mothers or aunts or sisters have been called for screening, they may then have imaging, and they may be totally asymptomatic. In other words, they have no symptoms, but they have some imaging, which then pushes them to the left of that slide towards clinical examination. So you've got these two things which are used, these two modalities which are used, one for the symptomatic, one for the asymptomatic, and then there's a crossover between the two. Okay. Now, there are all sorts of issues about both of these types of approaches. But anyway, enough to say that essentially you have both of these approaches. with clinical examination, obviously there are issues around the size of the mass that is being palpated, that's the word, palpated, so that's being felt, in other words. So the mass of the size, in the breast in this case, or it could be in another part of the body, that is actually being palpated or clinically examined. Also, aspects around its macroscopic shape, size, texture, yeah, many things about its macroscopic feel. Imaging, on the other hand, is meant to be much more objective, yes? It's meant to be something that doesn't require something subjective like feel, touch, etc. It's meant to be very, very subjective. And clinically, imaging is more sensitive. It will pick up smaller lesions than clinical. Okay? So clinical would probably pick up masses which are round about 1 centimetre in diameter, roughly. Depends who the clinician is, how many times they see or feel a breast cancer, but generally about 1 centimetre in diameter, whereas imaging typically would be round about 0.5 centimetre for an X-ray. Different imaging will have different sensitivity. Okay, so the two parts of the triple assessment, two of the parts of these three assessment modalities are then the clinical and the imaging. And there's been a huge, huge, huge amount of work going into all of that. And just a little aside now, you are cancer biologists, so I hope you're thinking to yourselves, aha, the biology of this. If I was in the unfortunate position where I had to have a mass in some organ, clinically palpated, and she's just told me that it needs to be 1 centimetre in diameter, what questions would you be thinking of as biologists about that, from cancer biology perspective? Good point. Is it originally from the organ where it's being palpated or imaged? That's a very good, very, very important point. What else what other sorts of questions about the cells might you be thinking about? Remember, these are possibly cancerous, malignant, aggressive cells. What question might you think if Miriam says to you, in order to touch this thing and feel it, it's going to be a whole centimetre in diameter? What would your thoughts be about that? Yep, go ahead.
But clinical examination wouldn't confer with an accurate diagnosis that, it is malignant.
Very good, very good. So we'll come on to the third modality. Very good.
Because,
yeah.
Because normally when a woman is about to have a period or it's hormonal, she might sometimes have lumps in her breast.
Very good, very good. So what you're saying exactly here is, how does this possibly cancerous lump or mass relate to the normal architecture? Is it just normal or is it different? Can we be more specific? But I'm trying to get at something else here. I'm telling you that in order to, if you were in the unhappy position where you went to your GP and you're really worried, if you're a chap, you think you might have testicular cancer. If you're a lady, you think you might have breast cancer. And I'm telling you, your GP can only feel this thing when it's 1 centimetre in diameter. What do you think? How many cells would that equate to? Hopefully you're cell biologists as well as biomedical, biochemical, whoever you are in whatever degree you're doing. How many cells do you think that might just roughly equate to? Because I would be worried about that. I would think to myself, how many cancerous cells have I actually got in that mass that have to be essentially treated? A lot. I like that. That is very true. There is a lot. How could you calculate the number of cells then? I'm going off on a tangent. Apologies. I know that you are limited in time. But I think it would be important. I think for me personally, I think it's really important to know how many cells you're looking at, aren't you? Because you have had lectures about cancer genetics and the changes that happen. You know, there are many changes that can happen genetically from a mother cell to a daughter cell to the offspring to many, many cells. So if you've got this mass and it's a centimetre, how many cells do you think? Any idea? Just give me a ballpark. Anyone? Roughly. All right. How would you calculate it? Come on, guys and girls. How would you calculate the number of cells in a centimetre cubed? I'm not going to ask, don't worry, I'm not going to ask you to calculate it, because I'm a notoriously bad mathematician and I don't want to embarrass myself in front of all you lovely young people. So tell me, how would you calculate? If I come on, what do you need to know in order to work out how many cells are in a centimetre cubed? Come on. Okay, the size of the cell. So you just take the size of the cell, average size of the cell, and you divide it into the volume of a centimetre cubed. And then, if I told you that the size of a cancer cell is about 20 microns, hopefully you think to yourself, that's big, first thing. And then the second thing you think is, okay, how many times can 20 microns cubed go into a 1 centimetre cubed? And for those of us who don't like doing maths at this time of the morning, I can tell you it's about 1 billion cells. All right, it's about 1 billion, approximately. So you might like to remember that. I think it's absolutely staggering and very, very depressing. Anyway, I've taken a little bit too much of your time. I just want to tell you that in order to do that, you probably are looking at about 1 billion cells. That is a lot of cells, okay? That is by anybody's estimation. And they are going to have clonal diversity, aren't they? They're not going to be monoclonal. They're going to be multiclonal, many, many different clones. So, in order to cure cancer, you need an imaging or you need some protection system that is going to detect these cancers very early. And in practice, what happens is you might have something like that. You might have about half a centimetre cubed, so you might have, I don't know, 1/4 billion cells. You've still got a lot of cells there, which may have done all sorts of things in terms of cell biology by the time it's detected. Okay, so that is the challenge for you, because I shall be retired later, at some point. Anyhow, let's say then, for example, that you get this clinical examination, you get the imaging, you do indeed need something else. You need something else to tell you this is not a lump which is just a normal change, okay? You need some other type of confirmation. And next week, we shall be going up into the lab, and you will be looking at some biopsy specimens. So this is an example of where a woman has had a needle put into the mass, and they've pulled out the cells, and they've stuck them on a glass slide. So it's cytology. These days, depends who you talk to, but many people don't like cytology because they feel it's rather objective, rather subjective, not very objective. So they prefer histopathology, of which Tony Madgwick, my esteemed colleague, is very knowledgeable. And we shall be looking at some histopathology next week in the lab. What we're looking for here is we're looking for a change from what we would expect from normal cells to very aggressive or malignant cells. That's what we're looking for. Now, you are aware that you would already be familiar with some things that you might like to look for, because you've already learned a little bit about cancer biology. So I hope that the most obvious thing you might look for is what? It's a teaching/revision session.
Lack of cell adhesion.
Lack of cell adhesion, very good. So lack of cohesion, in this particular case, dispersion. So loss of cell-cell interactions, very, very important key aspect of cancer biology. We know that's one of the key things. You lose adhesion molecules between the cells. Allow them to become motile, travel to other parts of the body. Other things? Come on. Obvious. Very obvious.
Invasive growth.
Invasive growth, very good. Okay, so you're now looking at, so these are all things you could look at. What else are you looking at though? What's the most obvious thing that you know happens when cancer starts. You get a loss of what? Control of what? No, I'm talking now about what actually happens within the cancer cell itself. Within the cancer cell, what is happening to allow the cell to turn into a mass of cells? What's going on? It's very obvious. Loss of cell control, mitoses, cell division. So you're looking for these very key characteristics. So all of that, using just that, sorry, I don't think so, anyway. That's what you're doing. You're looking for changes in the size and shape of the nuclei. You're looking at loss of adhesion between the cells. You're looking at cell proliferation, all in one of those. Anyway, there we are. So, there are advantages and disadvantages of every single technique that is going to be used. But without exception, in order to diagnose cancer, and if anyone you ever come across tells you that they've had a cancer diagnosed using just one of these techniques, please immediately suggest they go and see some other clinical person. Because they would never now just use one of these techniques, because none of these in their own right are going to be specific enough. You need to have all three together, picture is built up, you then make a diagnosis. Okay. Now, I am very biased towards breast cancer, please ignore this as we'll start. However, we should have realised there are other types of cancer, of course. So, yeah.
Mriam, is it true that such masses are painless?
Absolutely, and that's a really good question. Are these masses painful or painless? They would only be painful if they hit a nerve. So if you had a cancerous growth and it grew near to a really quite a big nerve bundle, then you would get pain. And there's a lot of tosh in the general public's eye and literature. I mean, one of the things that people say is someone hit me, bad stories I've heard anyway, but for example, I was hit in the breast and I now have breast cancer. Actually, there's no evidence whatsoever that an impact would cause a cancerous change. So, but there's a lot of sort of myths around it, but for sure, if you have a large enough mass, you will get a pain, because by default, it will have grown to a size where it will have hit a nerve. Because, you know, anatomically, from your last year, there are nerves all over the body, and in the breast there are lots of nerve bundles as well. So sometimes there will be pain, but on the whole, not necessarily. So this guy, and there are other risk factors, and you're going to have a session separately around factors that might be important to consider when considering diagnosis. But if we think about colorectal cancer, which is very commonly diagnosed at a late stage, there would be a pain, or there would be blood in the feces, and the individual would go to the doctor, and the doctor would say, you need some imaging, colonoscopy, where they clear out the bowel first, and then they put a light emitter. They basically put a little brain's gone. But basically it's a wire with a light at the end, and you can have stereotactic biopsy using that type of imaging. So it's endoscopy, well, it's in this case it's colonoscopy, so it's going into the colon, and it is then biopsying, and at the same time you're getting imaging with the colonoscopy, but you would probably also have X-ray and or MRI imaging. So for colorectal cancer, you would have the colonoscopy, because you can't actually have palpation in the colon, not possible, unless it was at the anal end, really nearby. So it would be colonoscopy, followed by biopsy, followed by imaging. So you've got a triple assessment there, haven't you, again? If you think about cervical cancer, you would have a smear test, which essentially is the biopsy, yes? you would, actually I should have put that on here, you would have palpation, you would normally have, if there was a suspected smear test, you would then go in and there would be physical examination. And then you might have imaging, but in the case of cervical cancer, most likely that smear test would be used for HPV testing. Yeah? So now, I just came back from 2 really interesting conferences. One was, luckily for me, in the Caribbean, which I really enjoyed immensely, and then the other one was in Liverpool, which I also enjoyed immensely. But both of them were on cancer biology. And the one in the Caribbean was absolutely fascinating around the HPV and cervical cancer. As you may know, some women here who are young enough may have been, either they or their sisters may have been offered the vaccine for HPV. And that vaccine is actually against 2 strains of HPV, HPV 16 and 18. Now, if you go to the Caribbean, and you sample the population of women and men in the Caribbean, it's strains 18 and 16 are not the most common strains. In fact, in the Afro-Caribbean population, it's more strains, I think, 8 and 40. So there are 2 other strains. So, and in fact, in London, which we have, I mean, I don't know how many people here are born and bred in London, but we have a lot of people here, I'm sure in this room, we've got a lot of people who are not born and bred in London. And so we have a lot of people coming from all different parts of the world with different strains of HPV. And so there's a big question around HPV vaccination, what strains you should use. And in fact, the HPV strains that are now being used, there's a vaccine that's going to come out next year, which is going to have 9 different strains in the vaccine, in order to hit all the HPV that could be around and about in the local area where the vaccination is happening. So at the moment, I'm telling you that cervical cancer is tested using a pap smear and quite often with HPV status. At the moment in the UK, the status is 16 and 18, but you should be inquiring minds thinking to yourself, hang on, would they be the right ones to test? Yeah? Maybe in the London population of women of a certain age, actually 16 and 18 are not the right strains to test. So, think about that. Interestingly, with regard to this, that HPV vaccination strategy is around prevention of cervical cancer, isn't it? And I have always said, I think it's totally unfair that it should just be the girls that are vaccinated. I have 2 teenage girls, one hates needles, so she screamed and chattered and wouldn't get the vaccination. Anyway, the other one had the vaccination, so it's 50-50 in my household. I'm right behind vaccination, but I think chaps should be vaccinated too, because at the end of the day, they are spreading the HPV. Now, the idea behind the vaccination program is, ladies, you are vaccinated, so you can't give your boyfriend HPV. He could go and sleep with someone else who then has some HPV, pass it on to you. Hopefully, you'll have an immune response. So the enlightened Canadians, who some people might think are perhaps, you know, a bit different to us, but anyway, they have vaccinated their boys. The boys are being vaccinated. And in Australia, which I would say generally the culture is considered quite macho in parts, they are vaccinating the boys. But you can think to yourself, why are they not vaccinating the boys here in the UK? A question I asked at the conference. They said, if you have herd immunity amongst the women, that then will eventually produce herd immunity amongst the men, and therefore you don't need to vaccinate the men. And there is no, at the moment, there is no evidence that HPV causes penile cancer. However, penile cancer is massively on the increase, as is testicular cancer. And there's been no work, there's been very little work done looking for testicular cancer and HPV. So if you want to do an interesting project. And then if I could just add one lovely little thought to you, because you're not eating your dinner. Because of the problem with HPV and HIV, in fact, there is a reluctance in certain communities to use condoms. They don't like to use condoms, so I'm not going to use a condom. So how other way can I have sex that doesn't involve normal penetration? You can use your imagination. It won't be perhaps something you want to think about too much. But what I can tell you is that the increase in oral cancer with HPV in Africa has gone through the roof. So I said to my daughters, who really hate having a biologist for a mother, I said, heaven forbid you would never do anything like that. But if you were, the World Health Organization has just recommended that for oral sex, men should use condoms. I'll leave you with that happy thought. Anyway, I'm digressing far too far. Let's talk about prostate cancer then. Prostate cancer is something that happens in older men, and I guess probably very few of you would ever be in the category yet. So we'll move swiftly on. Prostate cancer is actually the most common cancer after lung cancer in men, and it happens really after the age of about 60. But it is particularly unpleasant because in order to identify prostate cancer, you have to have a biopsy, you have to have imaging, and then you have to have this thing which I have called DRE, just for the fact that it was quite a long name, which basically sounds very nice and technical, chaps. Digital rectal examination. And what this essentially means is a man has to have a digit, in other words a finger, inserted into the rectum in order to feel the prostate, in order to then diagnose, help with the diagnosis for prostate cancer. So there is a long way to go. We have lots of opportunity to do good work. And I think that this is an area of biology where we can actually make an impact. I put that little star there to say that the only molecular test so far is on the cervical cancer. And we're teaching you about molecular biology all the time. You've got to start thinking about how you can help the next generation, or even help yourselves, heaven forbid, if you get to the age of 65 and you need to be tested for prostate cancer. Wouldn't it be great if in 30 years' time you didn't have to have a finger inserted into your rectum because you developed a test that didn't require that? So I think there's opportunities. I should get back to the nitty-gritty of this lecture and stop digressing. So basically, each tumour type is diagnosed differently, but the principle is the same. It's imaging, it's clinical, and it's sampling, it's biopsy, yeah? So depending how you do the clinical is going to depend on the anatomical site. And remember that the palpation is about 1 centimetre, maybe a little bit less cubed, round about 1 billion cells, okay? So this is coming back to the question that was asked at the back. How do you know that with regard to clinical? And this is actually whether it's breast or any other part of the body. How do you know clinically that you have something that is cancer versus something that is normal? And if you have an organ of the body where there are changes, particularly in women, which might be changes in reflection of the monthly cycle, where they're hormonally responsive and you're getting changes in hormone every month, you can get changes in cellularity, and that can then change the clinical palpation, the feel, etc. So we have to put guidelines together. If you have a lumpy breast surface, that could just be changes in the connective tissue rather than actually, frankly, breast cancer. Whereas if you had a mass which is very much in one part of the breast only, and it persists throughout the entire monthly cycle, then and it's attached to the skin, it's non-mobile, then it's likely to be worth having it investigated. And this is the problem with having it just a clinical examination. The same goes for chaps in the prostate cancer. You can get changes which are due to some external factor that we're not actually aware of, which can lead to an increase in the size of the prostate gland, for example, infection. So men might think, oh God, my prostate gland has got really big, I've got a prostate cancer, but actually it's either an infection or it could be a benign change. So the 5 signs of breast cancer. There's been public awareness campaigns for breast cancer, bowel cancer and lung cancer, I think. Yeah, I think those are the ones, they're the main ones. So bowel cancer, people who are at high risk, and the fecal blood test. In other words, they take some of their feces and they send it off to the lab, a molecular test to screen for bowel cancer. Breast cancer, self-examination is the big push, isn't it? I would say most of you ladies here, all look fairly young. Please don't panic. If you are going to do self-examination, which is recommended, then you should make sure you do it at the same time every single month, and it should normally be 1 week after the end of the menstrual period, which is when the breasts are the least glandular. Chaps, if you want to check for prostate changes, that's up to you, but all of you look fairly young, so I think you... All right, we'll move on. Okay. So you need to have an understanding of that, of why that works, but why it doesn't work. So knowing that there are problems with that, specifically around the lack of specificity, yeah? It's not specific. You can just check something that has changed and is large. You don't know specifically what it is. So there's lots of different ways of then using imaging. How do these imaging systems work? There's 2 main imaging systems. There's others, but these are the 2 that are in most hospitals. And the first is ultrasound. All ultrasound does is making sonic waves, which then penetrate the tissue and bounce back. Yeah. So essentially, as it says here, they penetrate the tissue. The waves are reflected back and are detected. So the more waves that go through the tissue, the more acellular the tissue is. Okay? So if there's nothing in the tissue, if it was just water, the sound wave would go straight through it. Then the more cellular it is, the sound wave will bounce back. So different sound waves travel, at different speeds. What they do is they use a special gel on the skin. If it was a breast cancer that they were detecting, they put a gel on the screen, on the skin, and they put the sonic probe on top. Most people are aware of this from actually the imaging during pregnancy, of course, for looking at really actually quite fine changes. And in fact, some of you, I don't know if anyone's had a baby here, but basically they also can see blood flow as well, which is quite nice. So you can monitor blood flow with another probe, so you can actually see both at the same time. That actually, I think, is an area where we can do something more with cancer, because we know in cancer you've got growth of blood vessels